You wake up every morning convinced insects crawl under your skin. You show doctors pictures and lesions, but they see nothing. The itch controls your life. This is called Ekbom syndrome, and it's more common than you might think. Today we're not talking about lice or scabies. We're talking about the body convincing the mind or the mind convincing the body. Ekbom syndrome, aka delusional parasitosis, sits at the messy intersection of dermatology, psychiatry, and lived experience. Ekbom syndrome, aka delusional parasitosis, delusional infestation, is a persistent fixed belief of being infested with organisms, bugs, mites, worms, parasites, despite lack of objective evidence. It's uncommon, but not vanishingly rare. Estimates vary, roughly tens of cases per million per year, and it most often presents in dermatology or in the emergency department because symptoms are skin focused. The first step is identifying the class to rule out organic causes such as stimulant-induced tactile hallucinations or neurological disease and medication effects. You have to rule out other causes as well. Delusional parasitosis began in the 1930s because it was a time of massive anxiety about hygiene and infection. Tuberculosis, syphilis, lice, and scabies were common in Europe during that time. People genuinely feared infestation. That cultural backdrop could have fueled these delusions today. Ekbom wasn't looking for parasites. He was cataloging neurological and psychiatric phenomena. These patients were showing up everywhere, to dermatologists, neurologists, even general practitioners, insisting they were infested. Many brought samples in what we call matchbox sign, which could be little boxes containing dust, lint, or skin flakes they believed were parasites. Ekbom recognized the pattern, while others dismissed it as just hysteria. Patients often collect debris in small containers to prove their infestation. This became so classic, it's still in textbooks today. They bring their evidence in tiny matchboxes, convinced it's the smoking gun. In some households, multiple family members developed the same fixed belief, sometimes after one person infected the rest with the idea. It's fascinating because it blurs the line between individual and collective psychosis. If a couple lives together and one partner decides that they are infested with parasites and they're constantly feeding their partner that same information, then it is possible for them to both believe this and become psychotic and have delusions and hallucinations regarding parasites. Morgellons disease, often it's actually pronounced Morgellons. So I pronounced it wrong at least 15 times in the video, and I apologize. And I'm going to start looking up pronunciations for things that I'm unsure of. Overlaps with delusional infestation, and it made headlines in the 2000s. Patients believed fibers or threads were emerging from their skin. Joni Mitchell, who is a folk singer, publicly stated she had Morgellons. The CDC even did a big study on Morgellons in 2012 and found no infectious agent, linking most cases to delusional infestation. People don't develop just any delusion. The crawling, itching, infestation theme taps into deep primal fears about parasites, contamination, infestation, and loss of control over your body. You could compare it to other fear-based syndromes of the body, like you could compare it to syndromes like Cotard's delusion, which is when you believe you're dead, or Cagra syndrome, which involves believing loved ones are imposters. The tragedy is that many patients harm themselves trying to get rid of the infestation, scrubbing with bleach, pouring kerosene on their skin or cutting their own skin. Lots of people have minor skin sensations like itching, crawling, tingling, maybe after insect bites or after using certain shampoos, lotions, etc., topical ointments. Normally, one brushes it off. But in delusional infestation, small or vague bodily sensations like itching, picking, formication are misinterpreted as infestation. The person focuses a lot on these sensations and probably on physical evidence like skin flakes, fibers, debris, and this amplification and selective attention makes them feel real. Dopamine dysregulation is often suggested because excessive dopamine or altered dopamine signaling in certain brain circuits might cause or amplify somatic hallucinations or abnormal tactile perceptions. Some evidence from the dopamine transporter hypothesis suggests abnormalities in how dopamine is taken back up or cleared may play a role. Conditions that affect the nervous system or body chemical balance can trigger or worsen the sensations. Such as hypothyroidism, B12 deficiency, anemia, diabetes, infections, HIV, etc. If the body is already sending weird signals, the brain might misattribute them. Drugs and substances that alter perception, such as cocaine, amphetamines, and stimulants, are also known contributors. Isolation and stress. So, people who are socially isolated or under physiological distress may be more likely to have heightened bodily awareness and less external feedback or correction. Comorbid psychiatric conditions include depression, anxiety, and dementia, and these can distort perception or make one more vulnerable to fixed false beliefs. Once someone has formed a belief, like these sensations I'm feeling are parasites, confirmation bias starts to kick in. They begin to notice things that seem to confirm that notion, fibers, skin flakes, etc. They might discount doctors' reassurance because they're living with it every day. Poor insight and strong emotional investment in the belief makes it harder to shift perception even when evidence says otherwise. Perceptual hallucinations and tactile hallucinations like crawling, biting, stinging sensations are perceptual hallucinations or paresthesias, which are nerve sensations. And these may be real sensations, but not coming from parasites. The brain is mislabeling them. Stimulants like cocaine, methamphetamines, amphetamines can cause symptoms. There are nicknames like cocaine bugs or meth mites. These drugs elevate dopamine and norepinephrine, often producing formication, which is the sense of insects crawling on or under the skin. People may scratch to the point of skin damage, and with chronic use, the tactile hallucinations can harden into fixed delusions, which is then indistinguishable from Ekbom syndrome. Chronic cocaine users report formication in 40% of cases, and meth users show similarly high rates. PCP, which is a dissociative hallucinogen that can cause intense perceptual distortions, paranoia, skin lesions, and somatic hallucinations, sometimes is misinterpreted as infestation. Xylazine, or tranq, is a less studied drug in psychiatric literature, but anecdotal and clinical reports show it causes bizarre perceptual effects, agitation, and self-injurious skin picking, which can overlap with infestation delusions. Which just means if somebody has skin lesions from picking their skin, then they might see those lesions and think, this is further proof that I do have parasites, that there is something else going on. And then some other hallucinogens, which are very rare, like psilocybin and synthetic hallucinogens, can occasionally produce tactile hallucinations. These are usually transient, but in predisposed individuals, they may linger or could trigger delusional elaboration. When someone presents with suspected Ekbom syndrome, clinicians should always rule out substance use. That includes a urine tox screen, a careful history gathering of recent stimulant use, club drugs, contaminated opioids, possibly fentanyl laced with xylazine, things like that. Distinguishing between formication from intoxication/withdrawal versus a fixed, enduring delusional disorder. Because substance-induced cases may resolve with abstinence and treatment of the underlying substance use disorder, but true primary delusional infestation usually requires antipsychotic treatment. So not every case of Ekbom syndrome is psychiatric at its core. Meth, cocaine, PCP, or even fentanyl laced with xylazine can make your skin feel like it's crawling. We call that formication. The danger is when those sensations stick. When someone moves from a drug-induced itch to a lifelong conviction of infestation. That's why any good workup has to rule out substance first. True primary delusional infestation usually requires antipsychotic treatment. That's all for this topic. Thank you for being here. I'll see you next time.